Imagine you are 22 years old, you're an engineering student in your final year, and you're out playing football with your friends. You take a tumble, maybe get bumped during a tackle, and a few days later, while you're getting out of the shower, you notice something.
Right.
Your left testis is just slightly bigger than your right. But, and here is the crucial detail for you to picture, it doesn't hurt.
Exactly.
There's no pain, no fever, no redness. You forget, you just knocked it during the game, so you ignore it. And you ignore it for 3 whole months.
And that 3-month delay, that incredibly human and, well, seemingly logical decision to wait just because there isn't any pain, that's actually one of the most dangerous traps in all of medicine.
Yeah, because what you're likely looking at in that scenario isn't a lingering sports injury. It's a testicular tumor.
Right.
And breaking down the reality of that tumor is the exact mission for our deep dive today. We're taking all the medical literature, the surgical guidelines, and the clinical data on testicular cancer and giving you a shortcut to being completely well-informed about this disease.
Which is so important because it is the most common solid malignancy in men between the ages of 15 and 35.
Right, guys, in the absolute prime of their lives. So understanding the biology and the warning signs, it could literally save your life or the life of a young man you know. Because this disease is extremely curable if you catch it early, but it is just absolutely tragic if you miss it.
Yeah, the paradox of this specific cancer is truly profound. On one hand, you've got a young man facing a terrifying, life-altering diagnosis. But on the other hand, we're looking at what is arguably one of the single greatest triumphs of modern oncology.
Let's unpack that triumph right away just to give you some context. The numbers are staggering. We are talking about an over 90% cure rate in the early stages.
Which is incredible.
I mean, think about Lance Armstrong. The man had stage 3 testicular cancer. It had spread to his brain, his lungs, his abdomen. The disease was everywhere. And not only did he survive, he went on to win 7 Tour de France titles.
Yeah, the prognosis can be unbelievably good. But that success rate, it's entirely dependent on understanding the underlying biology. The margin for error is incredibly thin here.
Wow, really?
Oh, absolutely.
Yeah.
A single misstep by a doctor in the initial diagnosis, or like a single incorrect surgical approach, that can alter that young man's life forever. You can't treat this blindly. You have to know exactly what you're fighting.
So to figure out how to cure it, we first have to understand what it actually is. When I was looking through our sources, I realized that testicular cancer isn't just one monolith of a disease. It's actually a blanket term for several wildly different things.
Oh yeah, it's a highly varied landscape. The very first thing oncologists do is divide these tumors into 2 major biological families. The vast majority, roughly 90 to 95% of all testicular tumors, are what we call germ cell tumors.
Okay.
And then the remaining 5 to 10% are non-germ cell tumors.
Let's slow down and define that for a second. What exactly is a germ cell? Because I hear the word germ and I immediately think of like a virus or bacteria on a doorknob.
Yeah, I know, it's a confusing historical term. In human biology, a germ cell is essentially a specialized reproductive cell. So in men, these are the cells inside the testes that are destined to divide and mature into sperm.
Oh, I get it. So they're meant to create life.
Exactly, because their entire job is to create a new human being. These cells possess this unbelievable capacity for rapid division and transformation. They're basically stem cells with limitless biological potential.
So if a germ cell goes rogue, you basically have a confused stem cell that has forgotten what it's supposed to grow into, and instead it just starts rapidly building an aggressive, chaotic tumor.
That is a perfect way to visualize it. And that giant category of confused germ cell tumors is further divided into 2 crucial subtypes.
Okay, what are the buckets here?
First, you have seminomas, which make up about 30 to 40% of all cases. They're the most common single type. And second, you have non-seminomatous germ cell tumors, which we often just abbreviate as NSGCTs.
Right. And what makes up that second group, the non-seminomas?
It's a cluster of different, highly aggressive tumor types. You have embryonal carcinomas, yolk sac tumors, choriocarcinomas, and teratomas.
Wow, that's a mouthful.
Yeah, and they can occur purely on their own or, more terrifyingly, they often mix together into one single multi-headed tumor.
So why does this distinction matter so much, like seminoma versus non-seminoma? Does the treatment change that drastically?
It changes the entire battle plan. The biology dictates the vulnerability. Seminomas, for example, they're composed of very uniform cells that divide in a predictable way. Because of that structural uniformity, they're highly sensitive to radiation therapy. The radiation can shatter their DNA fairly easily.
Okay, but the non-seminomas.
The non-seminomas, those chaotic mixtures of different tissues, they're generally resistant to radiation. They require a completely different approach involving complex chemotherapy.
Oh, wow. Okay, that covers the massive germ cell majority. But what about that smaller 5 to 10% category, the non-germ cell tumors?
Right, so those arise from the supportive scaffolding of the testes rather than the sperm-producing cells.
The scaffolding?
Yeah, the surrounding tissue. You have Leydig cell tumors, which can actually hijack the body's endocrine system and produce excess testosterone or estrogen, leading to systemic hormonal changes.
That sounds intense.
It is. And you also have Sertoli cell tumors, which are mostly benign. But there's a fascinating quirk in the epidemiological data regarding age that frequently catches doctors off guard.
Yeah, here's where it gets really interesting for you listening. There's a massive shift depending on how old the patient is.
Exactly. If you're evaluating a man over the age of 50 who presents with a testicular tumor, the most common type is actually none of the ones we just mentioned.
Wait, really?
Yeah, it's lymphoma.
Lymphoma, a blood cancer, right. A cancer of the immune system manifesting in the testes as the primary site. How does that even happen?
Well, as men age, the primary germ cells in the testes slow down their active division, which significantly reduces the risk of germ cell mutations.
Hmm.
But at the same time, the aging immune system undergoes senescence. Lymphocytes, which are white blood cells, naturally circulate through the vascular network of the testes.
Right, the blood supply.
Exactly. And in older men, mutant lymphocytes can settle in that tissue and begin rapidly multiplying. Because it's a completely different disease process, a blood cancer rather than a reproductive cancer, the treatment protocol shifts entirely.
Which really underscores why accurate classification is the absolute foundation of survival.
100%.
So since the tumor types are so incredibly varied, ranging from confused stem cells to immune system lymphomas, how does the body actually warn us that this is happening? This leads us right back to our 22-year-old engineering student. The clinical presentation is, honestly, terrifyingly quiet.
Yeah, it's the trap of painlessness. As a society, we're culturally conditioned to equate serious illness with severe agonizing pain. If something is killing us, we expect it to hurt. But the classic presentation of a testicular tumor is simply a heavy, painless lump.
See, I really have to push back on this because it just defies common sense. If you have a rapidly growing tumor, an abnormal mass of cells physically expanding inside an enclosed organ, why on earth doesn't the body sound the alarm with pain?
You would think it should, I know.
Well,
But pain in human organs usually arises when protective capsules are acutely stretched, when there's massive inflammation, or when nerves are directly compressed.
okay.
Testicular tumors typically grow insidiously. They expand slowly enough that the surrounding tissue just kind of accommodates the growth without immediately stretching the nerve-rich outer capsule.
So it's basically sneaking up on the nervous system.
Yes, pain only happens in about 10% of cases. When a young man does feel acute pain, it's usually because the tumor has grown so rapidly that it outstripped its own blood supply.
Oh man, so part of it dies.
Exactly. A section of the tumor dies and ruptures, causing a hemorrhage inside the mass. That sudden internal bleeding causes rapid swelling, acute capsular stretching, and sudden agony. But for the other 90% of men, the sheer lack of pain gives them a false sense of security.
So they wait. They assume it's a cyst or a sports injury, and by waiting, the cancer spreads.
Yes, unfortunately.
And because the cancer is sitting there quietly, locally, it can start presenting in some truly bizarre ways that don't seem connected to the reproductive organs at all. What happens to the guy who ignores the lump?
Well, he might end up at a totally different specialist for a seemingly unrelated problem. A patient might come in complaining of a dull, relentless backache.
Which, for a young active guy, you'd assume is a deadlifting injury or something?
Exactly. But that backache could actually be the result of the cancer spreading up the lymphatic highway and forming a massive secondary tumor in the retroperitoneal lymph nodes, which are deep in the back of the abdomen, pressing directly against the spinal nerves.
Wow. Or shortness of breath, right? You go to a clinic thinking you have adult-onset asthma or a lingering chest infection, but an X-ray shows it's actually a lung metastasis.
Exactly that. Or consider a deeply distressing symptom for a young man. He starts developing actual breast tissue, a condition called gynecomastia.
Wait, from testicular cancer?
Yes. Why? Because certain aggressive tumors, specifically choriocarcinomas, secrete massive amounts of a hormone called hCG.
Ah, okay.
The body's endocrine system gets completely confused by this hormonal surge, leading to spontaneous breast development.
Hmm.
Or, shockingly, the very first symptom a man might notice is a swollen, hard lymph node right above the collarbone in the neck,
In the neck, what do you call that?
the supraclavicular node.
So the primary tumor in the testes goes completely unnoticed, and the guy walks into the doctor's office because of a lump in his neck. That is wild.
It really is. And this creates an absolute, non-negotiable rule in clinical practice. Any young man who presents with an unexplained lump in his neck, or mysterious breast tenderness, or an unyielding backache, must undergo an examination of the testes.
Knowing this, who is most at risk? Is this a purely random lottery, or are there underlying biological factors that put someone in the crosshairs?
There are definitive risk factors. A family history, like having a father or a brother with the disease, significantly increases the odds.
What about if you've already had it?
Yeah, having already survived testicular cancer gives you a 2 to 3% lifetime risk of developing a brand new primary tumor in the remaining testes. Genetic chromosomal conditions, like Klinefelter syndrome, also play a major role. But the single most significant documented risk factor is a condition called cryptorchidism.
Cryptorchidism?
Yeah.
That simply means an undescended testis, right?
Exactly.
Let's dig into the mechanics of that, because the data says an undescended testis carries a 4 to 10 times higher risk of developing cancer.
It does.
But why? Why does the mere physical location of the organ suddenly make its cells turn malignant?
To understand that, you have to look at the evolutionary biology of human anatomy. The human testes is biologically engineered to function outside the core of the body, suspended in the scrotum, for one very specific reason.
The temperature rule.
Exactly, the temperature rule. The testes requires an operating environment, about 2 degrees Celsius cooler than core body temperature, to produce sperm properly and maintain healthy cell division.
Oh, wow.
So during fetal development, the testes actually form up near the kidneys and slowly migrate down.
Wait, they start up by the kidneys.
Yeah, they do. And if one fails to descend and remains trapped inside the warm environment of the abdomen or the groin canal, it experiences constant, unnatural thermal stress.
So it's essentially baking inside the body.
Yes, and that chronic thermal stress is devastating at a cellular level. It denatures proteins, increases oxidative stress, and disrupts normal cellular replication. Over years, this massively increases the chance of those germ cells mutating and turning malignant.
Even if they fix it later, like with surgery.
Even if a pediatric surgeon brings the testes down into the scrotum later in childhood, which is a procedure called an orchidectomy, the risk is lowered, but it never returns to baseline. The DNA damage from that early, prolonged thermal exposure is already done.
Man. So because the physical symptoms can be so deceptive, so painless, and masked by these weird secondary symptoms, we clearly need foolproof ways to look inside the body and see what's really going on. Let's talk about the detective work. What is step one when a patient finally comes in with a lump?
Step 1 is establishing the 99% rule using a scrotal ultrasound.
Okay, an ultrasound.
It's incredibly fast, completely painless, and highly accurate. It answers the most vital anatomical question for the physician. Is this mass extratesticular, meaning it's outside the actual tissue of the testes, or is it intratesticular?
And if it's outside, it's usually something benign, like a cyst or a swollen vein.
Right.
But if the ultrasound shows a solid, dense mass inside the actual meat of the testes,
Then it's a tumor until proven otherwise. The imaging gives you the structural reality. You don't wait for it to grow, you act.
but the ultrasound is just a black and white picture. We also have to look at the chemistry of the blood. And this is where we get into what the medical community calls the biochemical fingerprint, or the holy trinity of tumor markers. You draw the blood, and the cancer literally leaves a chemical signature.
It's an incredible diagnostic tool. Before a surgeon ever considers taking the patient to the operating room, they must draw blood for 3 very specific markers: AFP, beta-hCG, and LDH.
Hold on, let's slow down. You just threw out an alphabet soup of medical acronyms there. Walk me through exactly what these are and why a simple blood test is suddenly as important as a surgical scalpel. Let's decode the trinity. What does AFP, or alpha-fetoprotein, actually tell us?
Well, AFP is a specialized protein that is normally only produced by the liver of a developing fetus. In a healthy adult man, it should be practically undetectable. If you run a blood test and AFP is heavily elevated in the presence of a testicular mass, it tells the doctor immediately that they are dealing with a non-seminomatous germ cell tumor, specifically subtypes like embryonal carcinoma or yolk sac tumor.
Right.
And this leads to a golden rule in pathology. AFP is never, ever elevated in a pure seminoma.
Wait, what happens if there's a disagreement? Say a pathologist looks at a biopsy slice under a microscope and says, good news, this is a pure seminoma, highly treatable,
Yeah.
but the blood test comes back showing high AFP. Who's right?
The blood test absolutely wins.
Yeah.
Oh yeah. A pathologist is only looking at incredibly thin slices of a tumor. They might literally miss a microscopic 1 millimeter cluster of aggressive non-seminoma cells hiding in a corner of the tissue.
Ah, I see.
But the blood circulates through the entire volume of the tumor. It catches what the microscope misses. If AFP is high, you must treat the patient for the more aggressive non-seminoma, regardless of what the visual biopsy says.
That is fascinating. Okay, marker number 2 in the trinity, beta-hCG. We briefly mentioned this hormone earlier as the cause of man boobs.
Yes, human chorionic gonadotropin. It's normally the primary hormone of pregnancy. It's actually the exact hormone that makes a drugstore pregnancy test turn positive.
So, bizarrely, a pregnancy test might actually turn positive in a man with this specific cancer.
It absolutely might.
Yeah.
It's highly elevated in that aggressive subtype called choriocarcinoma, but it can also be mildly elevated in about 10 to 20% of seminomas.
Okay, and the third piece of the puzzle, LDH, lactate dehydrogenase. What is its job?
So LDH is a structural enzyme found inside almost all living body tissues. It's released into the bloodstream whenever cells are severely damaged or rapidly dividing.
So it's not specific to just this cancer.
No, unlike the other two, it's not specific to testicular cancer at all. You can have high LDH from a severe heart attack, liver disease, or even intense muscle trauma. But in the context of a known testicular tumor, it correlates beautifully with total tumor burden.
Meaning, the higher the LDH level in the blood, the more physical cancer is actively dividing inside the patient's body.
Exactly. You combine these 3 blood markers with advanced imaging,
Mhm.
like CT scans of the chest, abdomen, and pelvis, to see if the cancer is physically spread, and you stage the enemy.
Let's ground this staging in reality because it can sound like a math problem.
Mhm.
Imagine we're tracking this cancer like a fugitive. We use the classic TNM system.
Right.
Stage 1 means we've caught the fugitive while he's still hiding out in the original house, like the tumor is confined strictly to the testy.
Yeah.
Stage 2 means the fugitive has escaped the house and hit the local highway system. The cancer has reached the retroperitoneal lymph nodes in the abdomen. And stage 3 means the fugitive has crossed state lines and set up camp far away, distant metastasis to the lungs, liver, or brain.
That analogy tracks perfectly.
Yeah.
But testicular cancer is unique in oncology because it adds an S category to that standard staging, specifically for the serum markers we just discussed.
Oh, S for serum.
Exactly. S1, S2, or S3 tells you how aggressively those chemical signals are pumping into the blood. And for metastatic disease, doctors use the IGCCCG classification.
There's another massive acronym. The International Germ Cell Cancer Collaborative Group. What do?
They created the definitive roadmap for advanced disease. The IGCCCG system looks at the histology, meaning the cellular makeup of the tumor, combined with the blood marker levels and the location of the metastases.
Okay, to group them.
Right. It categorizes the patient into good, intermediate, or poor prognosis groups. A patient in the good prognosis group with a non-seminoma has a 5-year survival rate of over 90%. If they fall into the poor prognosis group, that survival rate plummets to around 50%.
Wow, that's a huge drop.
It is. This classification dictates exactly how intensely we need to treat the patient chemically.
So if the IGCCCG classification tells us we're dealing with a highly aggressive, intermediate, or poor prognosis tumor, we know exactly what we're up against. But before we can bombard the body with chemicals, we have to physically remove the primary threat. We have to take the tumor out. But doing this wrong can literally be a fatal error.
This brings us to the cardinal rule of surgical oncology for this specific disease. A surgeon must perform a radical inguinal orchidectomy.
Stop right there. Inguinal orchidectomy. When I was reading the clinical guidelines, this part completely blew my mind. The tumor is sitting right there, physically in the scrotum, but doctors are explicitly taught that they must never, ever make the surgical incision in the scrotum.
Never.
They're forbidden from biopsying the tumor through the scrotal skin. They have to go in high up through the groin, the inguinal region. Why?
To understand the danger, you have to look at the lymphatic drainage. The lymphatic system is the network of vessels the cancer uses as a highway to spread throughout the body. Remember how we discussed the testes developing in a fetus high up near the kidneys and then migrating down?
Yes, the temperature descent.
As it descends, it drags its original blood supply and its original lymphatic vessels all the way down with it. Therefore, The internal lymphatic drainage of the testes flows deep, back up into the abdomen, into the periaortic lymph nodes near the kidneys.
But the skin of the scrotum itself, where does that drain?
The scrotal skin is a completely different embryological structure. Its lymphatic vessels drain entirely differently. They drain to the inguinal lymph nodes, which are the superficial nodes right under the skin in the crease of the groin.
Okay, so making an incision directly into the scrotum instead of going through the groin is basically like opening the wrong door in a burning building and venting the fire out into a completely unburned, perfectly safe hallway.
That is a brilliant way to visualize it, yes. If a surgeon cuts directly into the scrotum and pierces the tumor, they alter the natural, predictable lymphatic drainage. They cross-contaminate the biological pathways. You take a tumor that was going to spread predictably deep into the abdomen, where we know exactly how to track and radiate it, and you spill live cancer cells directly into the scrotal tissues.
So you force the cancer to spread to the superficial groin nodes instead.
Right. You completely scramble the disease's natural pathway, making it incredibly difficult to track and much harder to treat. It is a catastrophic, potentially life-ending surgical error.
Wow. So to prevent that, the surgeon makes an incision in the lower abdomen, the groin, and literally pulls the entire spermatic cord and the testes up and out intact without ever violating or piercing the scrotal sac.
Exactly. They clamp the blood vessels high up first. That ensures no rogue tumor cells are accidentally squeezed into the bloodstream while the surgeon is handling the mass. Then they remove the entire structure as one single sealed package.
Amazing. But what happens after the surgery? I assume pulling the primary tumor out isn't the end of the story.
Far from it. The post-surgery path branches wildly depending on what our two main biological buckets told us. For stage 1 seminoma, which is relatively slow-growing and highly predictable, the patient actually has options.
Like what?
They can choose active surveillance, which means doing nothing but getting frequent scans. They can do a single mild round of carboplatin chemotherapy to sweep up microscopic cells. Or they can use localized radiation to the abdomen. All three options yield equivalent, near-perfect survival rates.
But what if the cancer has already escaped the house? What if we're dealing with advanced metastatic disease?
Advanced disease requires systemic heavy intervention, specifically BEP chemotherapy. That stands for bleomycin, etoposide, and cisplatin. It is the gold standard regimen that actually cures metastatic testicular cancer.
How do those drugs actually work together to kill the cancer?
They attack the cancer's ability to divide from multiple angles simultaneously. Bleomycin literally chops up the DNA strands of the cancer cells.
Okay, violent.
Very. Etoposide prevents the DNA from unwinding properly, so the cell can't read its own blueprints. And cisplatin is fascinating. It chemically binds to the DNA and cross-links it, essentially supergluing the strands together so the cancer cell cannot physically replicate.
Wow.
Yeah, it forces the rapidly dividing cells to undergo apoptosis or programmed cell death.
That is incredible. And after this intense BEP chemo, say you do a CT scan and you still see a mass left over in the abdomen, how do you know if the chemo actually worked?
This is where knowing your tumor type is, once again, the difference between life and death. If the original tumor was an advanced seminoma, that leftover mass might just be dead scar tissue. To find out, we use a PET scan, which detects metabolic activity.
And if it doesn't light up?
If the mass doesn't light up on the PET scan, it means the cells aren't eating glucose. It's dead. You leave it alone.
But wait, if the original tumor was an NSGCT, the chaotic non-seminoma group, the rules change entirely, right?
Radically. If a patient with a non-seminoma goes through BEP chemotherapy and they have a residual mass left over on the scan, you cannot trust a PD scan. You absolutely must go in surgically and cut that mass out.
Because of the teratoma.
Exactly. Teratomas are a specific subtype of non-seminoma that are fundamentally resistant to chemotherapy.
Why are they resistant?
Because of what they are. Chemo targets rapidly dividing immature cells. But a teratoma is a confused germ cell that is actually matured and differentiated.
What does that mean, differentiated?
It tries to grow into fully formed tissues. You can sometimes find actual hair, cartilage, or primitive bone inside a teratoma.
Inside the tumor?
Yes. Because these cells are mature and slow-growing, the chemotherapy drugs simply bounce right off them. The chemo will kill off the aggressive embryonal and yolk sac cells surrounding it, leaving the mature teratoma behind.
So a teratoma won't light up on a PET scan because it's slow-growing, making it look innocent. But if you leave it inside the abdomen...
It can slowly undergo malignant transformation into an entirely new, deadly form of cancer that won't respond to any drugs. It must be surgically excavated.
Got it. So the surgery is done, the chemo is finished, the residual masses are removed. Can the patient just walk away and get on with their life?
No,
You know,
because then enters the crucial surveillance phase. And this is where the holy trinity of blood markers makes its return. You rigorously monitor AFP, beta-hCG, and LDH every 1 to 2 months for the first year, alongside regular CT scans.
because as you said earlier, the blood circulates everywhere. The blood will often screen that the cancer is back before the CT scan even whispers it.
That is exactly the dynamic. We literally call it the blood test for cure. The microscopic chemical markers will begin to spike in the bloodstream months before a recurrent tumor is physically large enough to be seen as a shadow on a CT scan.
Oh, that's brilliant.
It acts as an early warning radar, allowing ontologists to jump back in and treat the relapse before it ever gains a serious foothold.
To pull all of this incredible medical science together, let's look at the big picture. We started with a 22-year-old engineering student ignoring a heavy, painless lump after a football game. The takeaways for you listening right now are absolute. A painless testicular lump is a surgical emergency. Do not wait for it to hurt because the pain is not coming.
That is the most vital message. Furthermore, the holy trinity of markers, AFP, beta-hCG, and LDH, must be drawn to map the biology before any scalpel touches the patient.
Right.
And finally, if surgery is required, it must be an inguinal orchidectomy through the groin, never through the scrotum, to prevent venting the fire into new lymphatic pathways.
It is a phenomenal story of human ingenuity. The fact that a stage 1 tumor has over a 98% cure rate, and that even metastatic disease with tumor spreading to the lungs and brain still boasts an over 80% survival rate. It truly is a masterclass in modern oncology. We've mapped out the biological buckets, we perfected the surgical maneuvers, and we engineered the chemical cures.
It's a profound success story. When the guidelines are followed and the biology is respected, we're able to give these young men their entire long lives back.
But as we wrap up, I want to leave you with a lingering thought to mull over. For all our absolute mastery over the staging, the robotic surgery, and the biochemistry, there are still massive, unexplained mysteries at the very heart of this disease.
Oh, definitely. The epidemiological data holds secrets that we still cannot decode, despite decades of research.
For instance, we know the mechanical steps of exactly how to cure it, but the root foundational causes remain entirely elusive. Like, why do Caucasian men have a 5 times higher incidence rate of testicular cancer than African American men? It's not a subtle statistical margin, it is 5 times higher.
And the medical community simply does not know why. It's not explained by disparities in access to care, nor is it linked to any known environmental or dietary factors. The fundamental biological mechanism driving that massive racial disparity is completely unknown to us.
It just proves that even in our most deeply researched, most highly curable cancers, the human body still holds profound secrets. We like to think of modern medicine as this clean, definitive X-ray, where every single mechanism is visible, solved, and perfectly understood. But the truth is always a little deeper and a whole lot more complex. Keep questioning what you know. Catch you next time.